Preeclampsia. What is preeclampsia? In this video tutorial, we're going to learn what is preeclampsia, how it occurs, when it occurs, the symptoms, and all of those things, so that you as a nurse, you as a healthcare provider, you as a healthcare professional, when a patient comes to you, you'll be in a good position to manage that person, that patient promptly, efficiently, and from a point of understanding. If you're a student, this is also going to help you pass your exams because I'm not leaving anything behind. So last year, time like now, I was invited to a workshop, and this workshop we were talking about this particular topic, preeclampsia. And in that workshop, there were women who had come and they had previously suffered from preeclampsia. They called themselves preeclampsia survivors, and this name actually captured my attention, like why, like what is this all about, what did they survive from? But as I listened to their stories, I was so shocked because of the knowledge gap. When this patient goes to the healthcare provider, you as the nurse, you as the healthcare professional, you see some signs. For example, you see the edema, and then you send this patient home. You tell them just elevate your feet, and you don't follow up with this patient. I found out that this patient went home and came back later with a lot of complications, and that is why they were calling themselves survivors. So you as a healthcare professional, you should not send this patient home, this pregnant mother home, without the necessary intervention when you know these signs, symptoms, because we should know how dangerous this condition is. So I want you to pay very good attention so that you don't miss a patient coming with this condition and risk sending them home and then coming back with complications, as we're going to be talking about. So what is preeclampsia? Let us talk about preeclampsia. So let us define what is preeclampsia. So I'll define preeclampsia as a systemic condition. So it is systemic because it affects all parts of the body. Does not just affect one part of the body. So it is systemic because it affects all parts of the body, and it normally occurs from week 20 of gestation. So from week 20 of gestation, a mom is maybe 21 weeks, 20 weeks, thereby it occurs from around that place, and it is characterized by increased or a high blood pressure in a normal intensive patient. That is a person who had never been diagnosed with high blood pressure before. And let us define, or let us see the characteristics of this blood pressure. So if a patient or if a mom, a pregnant mother, comes to you with a blood pressure of greater than or equal to 140 out of 90 millimeters of mercury, and then you take these blood pressure readings at least 4 hours apart and at least 2 times in that day, and the reading is greater than or equal to 140 over 90 millimeters of mercury, this is a clear indication of presence of preeclampsia. And another way that you can actually know that this patient has preeclampsia is when the systolic blood pressure is at least greater than or equal to 160 millimeters of mercury, and the diastolic blood pressure is at least greater than or equal to 110 millimeters of mercury, and you've taken this reading at least one time, it is also a clear indication that this patient has preeclampsia. So that is the characteristic of the blood pressure. And then preeclampsia is also defined as, yes, it is characterized by high blood pressure reading, but it is also characterized by presence of protein in urine. So if there is protein in the urine, then it is also a clear indication that this mom has preeclampsia, because protein is not supposed to be present in the urine. And then maybe when you are talking to this patient, when you are examining, taking history, you realize or you suspect multi-organ damage. It is also a characteristic of preeclampsia, and we're gonna be talking about how this looks like when we are talking about, the symptoms and how all of this comes about. So that is how you define preeclampsia. It is a systemic condition that is characterized, that occurs from week 20, that is halfway through the gestation, and then it is characterized by high blood pressure readings in a normal intensive patient. And if this patient has a systolic blood pressure greater than or equal to 140 out of 90 millimeters of mercury, and you've taken this reading at least 4 hours apart and at least 2 times, then you can be comfortable to say that this is a good candidate of preeclampsia. Or you've taken this reading at least once and the systolic blood pressure is 160 millimeters of mercury out of 110, and you've just taken this reading one, this is a candidate of preeclampsia. Also, if there's presence of protein in urine, then it is a clear indication that this mom has preeclampsia. And also, when you are doing your history taking, your examination, you sense or you suspect multi-organ damage from what the mom is complaining about, it is also a clear indication of preeclampsia. So that is how we would define preeclampsia. Now, in this next session, I want you to understand how preeclampsia occurs, so that when you are managing this patient, you can know how much of an urgent or an emergency this is, so that you don't send this patient home when they're supposed to be admitted for more care. So let us talk about the pathophysiology. How does this condition occur? So let us talk about the pathophysiology of preeclampsia. So how does this occur? Everything about this condition stems from the placenta. Everything comes from this placenta. In a normal circumstance, when a mom gets pregnant, maybe around at week 6 to about week 12, this is whereby the blastocyst is implanting in the uterus. So there's normally the implantation is taking place in here. Implantation. So these blastocysts, the cells of this blastocyst normally divides into 3. This is in a normal circumstance. So layer 1 of this cell, the outer cells, it's called the cytotrophoblasts. And then layer 2 is called the syncytiotrophoblasts. And then the third layer is called the extravillars. So this one normally forms the placenta. This is what becomes the placenta. These ones normally anchor the placenta. And then the extravillous trophoblasts, these ones normally form the invasive trophoblasts, and this is where every problem comes from. So in a normal placenta, these invasive trophoblasts, in a normal circumstance, these invasive trophoblasts normally they will penetrate assume this is the uterus. I'm not going to draw it very well. Assume this is the inner layer and this is the extravillous trophoblast. So these ones, they are going to penetrate through the endometrium, and then they should penetrate again through the myometrium. So this is the endometrium, then myometrium, and then they are going to invade the maternal spiral arteries. These ones, they're supposed to invade these maternal spiral arteries and transform them into something else. This is because these arteries, in a normal circumstance, they are normally narrow, and but when these ones, the extravillous trophoblasts, invade the maternal spiral arteries, they transform them, and they transform them by detaching their endothelial cells. So they'll detach the endothelial cells of these arteries, and by so doing, they are going to make them wider, because the whole essence of this is to make them wider so that more blood can flow to the placenta. I hope we are together. Please let me know if if you are understanding. So when they detach these endothelial cells, these maternal spiral arteries are going to lose their ability to contract. They are going to lose their muscle contractility, let me call it that way. And by so doing, they are going to stop being narrow and they are going to be wide. And when they are wide, then this is going to help. It's going to help the blood to flow in a low resistance and sufficiently. So these extravillous trophoblasts, they should penetrate deep and be able to transform these maternal spiral arteries. But what happens in a preeclamptic condition is whereby these extravillous trophoblasts, they are not able to penetrate deeper, and by so doing, they don't transform these maternal spiral arteries from being narrow into being wider, so that they can reduce the resistance of the blood flow. And by so doing, because there is no transformation, so these maternal spiral arteries still remain narrow, and that is why when the blood is being pumped from the maternal to the placenta, the resistance is high, and this is what causes high blood pressure. When the resistance is high, then there is reduced blood perfusion to the placenta. So what does this cause? So this means there is less oxygen supply to the placenta. There is less blood supply to the that is what it means. And by so doing, this causes ischemia of the placenta. Tell me, guys, are you understanding, or maybe I'm too complex? Let me know. So this causes ischemia, and this is where things start getting very serious. So as a result of this ischemia, some inflammatory molecules are released. And these inflammatory molecules, when they are released, their work is to damage blood vessels, and their work is also to cause or to increase inflammation, and their work is also to cause multiple organ damage. Tell me, guys, have you understood the pathophysiology? Like, how does this occur? So let us talk about these inflammatory molecules, because you may be wondering, how does this even occur? So one of them, so I'm going to characterize them into three. And category one is the anti-angiogenic factors, and category two, I'm going to call them, they are called the pro-inflammatory factors. These are the ones like interleukin 6 those ones, they are in the pro-inflammatory factors. And then number 3, I'm gonna call them, or they're called oxidative stress markers. So the work of these 3 inflammatory factors or molecules is to damage blood vessels, maternal blood vessels. That is why we said that this is a systemic condition, because it is going to affect almost all blood vessels. And then the other work is to cause multiple organ damage, and the other work of these harmful molecules is to cause widespread inflammation. That is why we're gonna see a lot of platelet demand, a lot of platelets being consumed, and that can cause a lot of things that we're gonna talk about when we are talking about the complications. So that is the pathophysiology of preeclampsia. I hope it is not so complex. Next, I want us to talk about the symptoms, and we're gonna see why this patient has these symptoms, why these symptoms present. It's because of all of these things that we have talked from above here. Now let us talk about symptoms of preeclampsia. When you spot a symptom, you're gonna know how much this preeclampsia has progressed, because we're gonna characterize these symptoms as classical signs, and we're gonna also characterize them as neurological signs and or symptoms, and then we're gonna characterize them as abdominal and liver symptoms. And we know that when it has got into the liver, you know that things are thick. Tell me, did you understand the pathophysiology? Like, how does this whole thing occur? Tell me there in the comment section. How was it? Was it very difficult for you to understand, or was it easy peasy? So let us talk about the symptoms, and we're going to start with the classic symptoms. Let us start with the classical symptoms, or the classic symptoms, and I know you know one of them. Which one? Which one have we talked about? I've already told you one. High blood pressure. High blood pressure in a normal tensive patient. So this is a patient who had not been diagnosed before with blood pressure, and I'm not going to explain that one because I already told you. But for the sake of people maybe who didn't watch part 1, the blood pressure in a normal tensive patient, whereby the systolic blood pressure is greater than or equal to 140 millimeters of mercury, and the diastolic blood pressure is greater than or equal to 90 millimeters of mercury, and you've taken this reading at least 4 hours apart and at least 2 times. So, and then the other one that we said is that when you've taken this patient has come to you and you've taken the reading 1 time, and the systolic blood pressure is greater than or at least 160 millimeters of mercury, and the diastolic blood pressure is greater than or equal to 110 millimeters of mercury, and you've just taken this reading 1, this is a clear symptom of preeclampsia. So high blood pressure, we've said that is symptom number 1. It's a classic symptom. And then another classic symptom is presence of protein. So there's presence of protein in urine, what we call proteinuria. And how is this? If it is greater than or equal to at least 300 milligram in a 24-hour urine sample. In a 24-hour urine sample. And then when you observe that urine, you find it to be at least it's foamy, or I would say bubbly, like it's bubbling. It's a good symptom. Another classic sign, I would say another classic sign is swelling. So I remember there's this patient I told you about in part 1 about this workshop that I went. So there's this patient a preeclampsia survivor patient, and she said that she went and for her prenatal checkups, and she had swelling on her feet and her arms, and this healthcare provider just told her to go home and elevate her feet. So that was a big mistake, because they did not see that as a classic symptom of preeclampsia. So swelling, or what we call edema, and this one, it can be on the hands, on the face, legs, yeah. And also in severe cases, a person may present with prevent with difficulties in breathing, difficulty in breathing, and this could indicate pulmonary edema. So that is in a severe case. In a very severe case, you can find that. So those are the classical symptoms. We've seen blood pressure, presence of protein in urine, that is proteinuria, and swelling. So please don't miss this. When a mom comes to you and they have these symptoms, these are classic symptoms of preeclampsia, and you should not miss these at all, because you're going to mismanage this patient. So let us talk about the neurological symptoms. And which ones are these? Like, what are some of these? And some of these could be signs of severe preeclampsia, or when it's getting worse. And I would say this one of them is, for example, severe headache. If this person has severe headache, how do you write headache? Severe headache, and it is persistent, and they are going to tell you that I've taken over the counter medications and nothing is working. So it is persistent, and it is not like you're not able to relieve. They've tried to relieve and it's not going away. And then another neurological symptom is vision changes. So they tell you that they are having blurry vision. So if the vision becomes blurry, or they tell you that, I can't see well, things like that. I am seeing some flashing lights, so they're having that, and this could be due to retinal damage or cerebral edema, and that is why I told you it's a systemic condition, because you can see it's even affecting the eyes and also a lot. So another thing that another neurological symptom, but this one is in severe cases, is whereby a patient, you may find Jesus. Oh, I have so much problems pronouncing that. So this one requires emergency. It's an emergency, this one, and we're going to talk about it when we talk about eclampsia, because this one is a complication of preeclampsia. Now let us talk about abdominal and liver symptoms. Abdominal and liver symptoms. So which ones are these ones? A mom will come and tell you that, I'm having some, my body is misbehaving. I'm having some epigastric pains. And or when you are examining them and you palpate around the upper right quadrant, they are gonna complain of pain. So pain on the right upper quadrant, that could indicate that these things are getting serious, because now it's affecting the liver. And we're gonna talk about one of the complications of having preeclampsia affecting the liver. Have you ever heard about the condition called HELLP? We're going to talk about that when we are talking about complications of preeclampsia. So epigastric pain, and when you're palpating during your examination, they have pain on the right upper quadrant. That is a symptom of preeclampsia. And then if they tell you that I have suddenly started or having, or if they tell you that they have nausea and vomiting, and they didn't have this before, or this one had ended, then consider that as a warning sign, or as a warning symptom. So let us also talk about kidney and fluid imbalance symptoms. For example, but these ones you may not really know if this is an outpatient patient, but let us just talk about them. So number 4, let us talk about kidney and some whereby you'll know that this person has preeclampsia from the readings or from your examinations or from your observations. If this person has oliguria or decrease in urine output, decrease in urine output, and I would say this at least if they have less than 500 mLs per day of urine output, it's a good symptom, or it's a symptom of preeclampsia, because this could indicate acute kidney injury from endothelial damage, because I told you that the inflammatory factors that are normally released from the ischemia of the placenta normally causes damage of the blood vessels, and the blood vessels of the kidney are not also spared. So if this person has urine output of 500 ml per day or less, then you can clearly see that they have oliguria, and it's a good symptom of preeclampsia. Also, shortness of breath, shortness of breath, and they can come to you having maybe coughs, or they have chest pain. Please don't ignore this, because it is a symptom, or it's a good indication of preeclampsia. So those are the symptoms of preeclampsia. And now in our part 3, we're going to talk about diagnosis of preeclampsia, like how can you tell that this person has preeclampsia from laboratory readings. That is what we are going to talk about. Let me know, have you understood about all of these symptoms that we've talked about? Classic symptoms, neurological symptoms, liver and abdominal symptoms, kidney and fluid imbalance symptoms, and we've also talked about shortness of breath. That the patient can present to you with cough and with chest pains, things like that. Tell me, have you understood? That? Now, you know what is preeclampsia. You know the pathophysiology, or how it occurs. You can identify the symptoms from afar. And now I want us to talk about how to diagnose preeclampsia. If you've not watched part 1 and 2, kindly start there, because it's going to help you understand this part better. So in the diagnosis, we're going to be doing blood pressure readings, because we cannot miss that. Like, that is the very first thing. And then number 2, we're going to also be doing some urine tests. That is very important. And then number 3, we're going to be reading some or we are going to be doing some blood work, and I'm going to be showing you what to check in this reading, so that you can know that indeed this patient has preeclampsia. So let us go to my little whiteboard. So that I can show you exactly what to look out for, so that you can clearly diagnose preeclampsia. So, welcome. Let's talk about the diagnosis. And number 1 thing is through the blood pressure readings. This one, we are not going to talk about it, because we've covered it in depth in part 1 and part 2, how to diagnose it through blood pressure reading. If you have not watched this, kindly watch part 1 and part 2. You're gonna see how. And then number 2, we've also talked about that it's also through urine tests, where we are talking about testing for presence of protein in urine. And in part 2, I've talked about that in depth also, and I've also given you the readings when to know that this person has proteinuria in the urine. In preeclampsia, I told you if the reading is at least greater than or equal to 300 milligram of protein in a 24-hour urine sample, then that is a clear indication of preeclampsia. In very severe cases, severe preeclampsia, this patient may have even up to 5 grams of protein in 24-hour urine sample. That is a very severe case. And when we are still talking about proteinuria, if you are using the urine dipstick, it should have at least 1 plus. That suggests preeclampsia, or that suggests at least this proteinuria. And also let us talk about PCR, that is protein to creatinine ratio. In this case, the reading is about greater than or equal to 0.3 milligram. It is diagnostic, like that is a good indication that there is presence of preeclampsia. So that is the urine bit, that is the urine test to detect preeclampsia or to detect proteinuria in a 24-hour urine correction, in a 24-hour urine collection. I've showed you the readings there. Kindly note that so that you don't miss them when you are doing your diagnosis. And now let us talk about blood tests or the blood works. Blood tests. What are you supposed to, what tests? One is the complete blood count, and this one you're gonna test, you're gonna observe, like for example the platelets. If they are less than 100, if they are less than this, then it is a good indication, or it is a good diagnostic of preeclampsia, and it could indicate there's hemolysis that is already taking place, and it's not a good thing. Also in the blood test, if there's a elevated liver function test, if the liver enzymes are elevated, for example the AST and also the ALT, it is a good indication, it is a good diagnostic of preeclampsia, because that means there's liver injury and possibly a good indication that there's gonna be some liver problems, liver associated complications or problems. And then kidney function tests, and then kidney function tests. We've talked about creatinine, elevated or increased creatinine. This one, if it's greater than 1.1 milligram per deciliter, it shows you that there's some acute kidney injury. Also some coagulation tests, that is number 4, that is the kidney function test. Coagulation tests are going to be checking the prothrombin time, and we're also going to be checking the INR, that is the international normalized ratio. We also going to be checking the D-dimer protein, and also the fibrinogen. I know you know these things, don't you? Let me know. So prothrombin time, the normal ranges are about 11 to 13.5 seconds. Please note that. So the normal ranges for this one, the prothrombin time. And prothrombin time is a test that measures how long it takes for blood to clot. It normally measures that. And in preeclampsia, the prothrombin time is prolonged, and maybe if if the prothrombin time is prolonged, it is a good indication of preeclampsia, and this is normally seen, especially seen in preeclampsia complications such as the disseminated intravascular coagulation, that is the DIC. So the normal range of this one of prothrombin time is at least 11 to 13.5 seconds. So if this is prolonged, then you know this a problem. And then when it comes to INR, that is international normalized ratio, the normal range here is about 0.8, this one 0.8 to 1.1. So the higher levels or high values normally indicate slower clotting, and it is not a good thing. It is it's going to be, or it is suggesting coagulation abnormalities or liver dysfunction syndrome. That is what we were calling the HELLP, and we are going to be talking about this when we talk about complications of preeclampsia. And then the D dimer. So D-dimer, I know you know, it is a protein fragment that is produced when a blood clot breaks down. We said about when the inflammatory factors from part 1, if you didn't watch that, when these ones are released, they cause a lot of damage to the blood vessels, and this is going to cause a lot of microclots in the blood vessels. And D-dimer, it is a protein fragment produced when blood clot breaks down, and we're gonna be using that to detect clotting disorders such as DIC. So in preeclampsia, when the D-dimer is elevated, it suggests excessive clotting activity, which may indicate, a complication such as the DIC. So, and then the fibrinogen, tell me, have you understood about that? What is Let us talk about fibrinogen. It is a protein that helps blood clot by forming fibrin. I know you know that. Fibrin, which is the structural component of a clot. And here the normal ranges that you are going to be observing are at least 200 to 400 milligrams per deciliter. That is the normal ranges. In preeclampsia, low fibrinogen levels could indicate increased clot breakdown, and this is commonly seen in DIC and severe bleeding disorders. So tell me, guys, have you understood all of these common diagnostic ways of knowing or understanding that this person actually has a preeclampsia? So that is all about this class on how to diagnose preeclampsia. Next, we are going to talk about, let's talk about management. So next class is we're going to talk about management. How should you manage this patient with preeclampsia? So you've done all these diagnostics and you know that clearly this person has preeclampsia. How should you manage this patient? I hope you've understood about how to diagnose preeclampsia from blood work, from blood pressure reading, from urine tests, and from kidney function tests, from all of that we've talked about. So now we're going to talk about how to manage preeclampsia. So you've done all the diagnostics and this patient clearly has preeclampsia. How should you manage this patient? That is our next session. Now let us talk about the management of preeclampsia. How do you manage this? And I want to mention that delivery is normally like the only cure for preeclampsia, and patients with preeclampsia without severe features are often or should be induced after 37 weeks gestation. And but before this, maybe before 37 weeks of gestation, the patient should be or is usually hospitalized and monitored carefully for the development of worsening, or if the preeclampsia is worsening, they should be monitored for that. So let us talk about the management, like how should you manage preeclampsia. So let us talk about management of preeclampsia, and we're gonna start with mild. If this person has, or if this mom has mild preeclampsia, how do you manage this? So number one thing that you're supposed to do is, of course, monitoring of blood pressure, and of course of the lab tests that we've talked about. It is very important to do periodic assessments of kidney and liver function, platelet counts, and urine and protein levels. It is very important. And another thing that you can do is also lifestyle modification. Lifestyle modification, if this person has mild preeclampsia, of course, encourage rest and reduce physical activity, but don't tell them to have a strict bed rest, because that is really not necessary. Diet, of course, they should at least maintain a balanced diet. And another thing that you're supposed to do in a person with mild preeclampsia is fetal monitoring. Make sure that you are monitoring, doing some regular ultrasounds to assess fetal growth, amniotic fluid levels, and also the NSTs, or the non-stress test, to monitor fetal well-being. It is very important. And also talk about the timing of delivery. For these ones, for people with mild preeclampsia, they can go to, or at around that 7 weeks, at or around there, delivery is normally recommended to prevent progression of this disease, So that is mild preeclampsia. So let us talk about now management of severe management, because this is where severe preeclampsia, like how do you go about this, because now here more is required of you. So number one thing that you need to do as a good healthcare provider is, of course, hospitalization. It is very important. This one you should do it for close monitoring and management. So hospitalization is very important. And number two thing that you need to do is the antihypertensive therapy. And these ones you can use medications such as labetalol, others like nifedipine. I know you know all of these ones. Hydralazine. These ones, at least they should be able to bring down the blood pressure to a normal or a good range. If this patient gets eclampsia, if this patient is eclampsia, how do you manage this? So magnesium sulfate is normally the first line of treatment for primary and recurrent eclamptic seizures. And you do this by give a loading dose of 4 grams. So you treat eclampsia or these seizures with magnesium sulfate, a loading dose of 4 grams of magnesium sulfate by infusion pump over 5 to 10 minutes. And then you're going to follow this by another infusion, by an infusion of 1 gram per hour. And you're gonna maintain this for 24 hours after the last seizure. So I hope you've understood that. So the loading dose is 4 grams given by an infusion pump over 5 to 10 minutes, followed by an infusion of 1 gram per hour for 24 hours after the last seizure. Let me know, have you gotten that? And then if this patient gets recurrent seizures, Hey, that word where if this person gets recurrent seizures, you're gonna do or you're gonna add an additional bolus of additional bolus of 2 grams or an increase in the infusion rate to 1.5 or 2 grams per hour. So you're gonna add that one, or an increase in the infusion rate of 1.5 or 2 grams per hour. See here we were given 1 gram, so you're gonna increase that to 1.5 grams or 2 grams per hour. Yeah, in case of these seizures are recurring or if they are recurrent. And then prophylactic treatment with magnesium sulfate is indicated for all patients with preeclampsia with severe features. So make sure that you are giving magnesium sulfate as a prophylactic. And then, so when it comes to fluid management, you should know that diuretics should be avoided. Will be avoided. Please don't do that. So because this can normally lead to pulmonary edema, and we don't want that really. So make sure that you are give at least or limit to at least 80 ml per hour. This one for fluids limit to at least 80 ml per hour or 1 ml per kg per hour. Please don't overload them with fluids because that could cause pulmonary edema, and that is very important for you to know. Let us now talk about postpartum management. So magnesium sulfate seizure prophylaxis should be continued for 24 hours postpartum. So magnesium sulfate, this one continue for 24 hours postpartum, and then LFTs, liver function tests, and platelet counts should document at least decreasing values before you discharge this patient. Elevated blood pressure readings should be controlled, of course, with the antihypertensives that we've talked about, for example, labetalol, and nifedipine. And then ensure that if this patient has undiagnosed, maybe if this patient is discharged with blood pressure medications, make sure that you do reassessments to see if the blood pressure readings are going down. So continue observing this patient for up to 4 weeks. And for eclampsia, even post-delivery, in most cases, preeclampsia, the blood pressure will return to baseline at least by week 12, by 12 weeks postpartum. So at least make sure that before these weeks postpartum are over, you are doing reassessments of the blood pressure and to check any progression of the disease. But that is generally how you manage preeclampsia, mild and severe. I hope we have understood that. So remember, we said that preeclampsia is only treated by delivery. So all of these things that we are doing here are to just manage the symptoms and just to make sure that the body is in a better position and not to progress into complications. Before we close this one, let us talk about complications of preeclampsia. Which ones are they? If you watched up to this level, I know now you are in a very good position to be able to manage and even treat preeclampsia. But we cannot end this session without talking about the complications of preeclampsia, and this is what we are going to talk about in this session. So let us talk about complications of preeclampsia. I know we've mentioned some, for example, HELP, for example, DIC. Which are the ones? Tell me there in the comment section before I show you the rest. So those are some of those ones, and we've also talked about eclampsia. So those are three ones that we've already talked about, but we are going to go a little bit in depth so that you can also understand how do these come about? How do these come about? So let us talk about complications of preeclampsia. So guys, let's now talk about complications. And in here we're going to talk about four of them. I know I've mentioned about three. So number one, let's talk about disseminated intravascular coagulation. How does this cause? How does this come about? So this is the first complication, and it normally occurs because preeclampsia induces endothelial damage, which we talked about. We talked about this in the very first part of this series due to the release of the inflammatory factors. So, preeclampsia-induced endothelial damage triggers widespread activation of the coagulation system, and this normally causes or leads to formation of microvascular clots. So, when there is endothelial damage, it will trigger activation of the coagulation system, and this is going to cause microvascular clots. When you hear about coagulation system, know that definitely we are talking about clots, formation of clots, destruction of clots, things like that. And this excessive clotting. So when there is excessive clotting, this excessive clotting will, of course, consume clotting factors and platelets, and this is going to increase bleeding risk. The risk of bleeding is going to increase because a lot of platelets and those clotting factors are being used to manage these microvascular clots that are forming. So I hope you are understanding that. And now, consequently, you know that this patient may experience uncontrollable bleeding, and you may find that this person is having bleeding gums, things like that, and having bleeding during delivery, things like that. And this could be one of the complications, and it is very risky, of course, when you hear about severe bleeding and you know that this person has consumed a lot of platelets and the clotting factors, the things can get quite thick at this point. So that is complication number one. So the second complication is HELLP. Tell me there in the comment section, what does HELLP syndrome stand for? What does HELLP syndrome stand for? So this one stands for hemolysis, elevated, liver, enzymes, and the low platelets. Of course, low platelets. So the endothelial dysfunction in preeclampsia. Again, everything about this is from what we talked about. The inflammatory factors from the ischemic placenta, from the pathophysiology. So there is endothelial dysfunction, and this is going to cause a lot of microvascular injury, particularly in the liver, and this is going to cause hemolysis. As you can see, the first H here is hemolysis, and this one, it's destruction of the red blood cells. As a result, there is going to be elevated liver enzymes due to liver cell injury, and also due to thrombocytopenia, that is low platelet counts from, of course, we've also talked about that from up there. So this combination is going to manifest as a person or a patient having pain in the right upper quadrant, as we talked about when we were talking about the symptoms. And also this person may also have things like jaundice and also an increased risk of bleeding and also liver complications. And number three, we're going to talk about eclampsia. This is whereby preeclampsia gets very serious and this person is going to have. Guys, tell me, how do you pronounce this word? Jesus. That one. Huh? So this person is going to present with. This person is going to present with Jesus. And this can result in cerebroedema and vasospasms. And that is very, very serious. And this can often disrupt normal neural activity and can lead to, a lot of those seizures. And this is a very, it's an emergency. It is an emergency because it can cause potential brain injury and an increased fetal and maternal mortality. I know you know that. And we've talked about how to manage eclampsia from our previous part. And then number four is acute kidney injury. Acute kidney injury. And also multi-organ failure. And this is again due to the systemic endothelial damage in preeclampsia, which will reduce or causes a reduction in renal blood flow. And this can impair kidney function. And this can cause acute kidney injury and renal impairment, which can contribute to things like fluid overloads, electrolyte imbalances, and accumulation of waste products, which can lead to multi-organ failure. I know you know that, and those are some of the complications. And you can see, guys, these complications are not a joke. I see a person bleeding anyhowly. Help. This one, it's also very serious. Eclampsia and acute kidney injury, all of these are very, I would call them fatal, and they can cause mortalities.